I'm Michael Bar-Ilan, Yechiel Michel, the Hebrew name given. I'm a physician and a professor in Tel Aviv University School of Medicine. I'm happy to call in the speakers, Professor Søren Holm, the first speaker, and Jonathan Kimmelman, the second. Søren, would you come? I know Søren for many years, like friends in the academic cycles. He is a professor of medical ethics. He's also a physician in University of Manchester and also University of Oslo. And Professor Jonathan Kimmelman is a professor chair of ethics in McGill University, Montreal. Søren.
Okay, thank you. Thank you very much. Thank you for the invitation to this very interesting conference, which touches upon very many of my academic interests. At the beginning, I need to acknowledge the European Union's Horizon 2020 research program, which at the moment pays me for thinking about these things. I also want to dedicate what I'm saying to my PhD supervisor and friend, Professor Henrik Wulff, who died last month, who was one of the founders of the European Society for the Philosophy of Medicine and Healthcare. And, well, people have already talked about their PhD supervisors. I think one of the most important things you can do in your academic career is finding the right PhD supervisor, the one who is also a good person. That is probably much more important than whether they are the best possible academic. Okay, so what I want to talk about is essentially precision medicine. I'll say a few words about the promise and the vision, then a few words about terminology, and then go on to discuss some of the problems that precision medicine raises for ethics, especially for research ethics and for issues of patient rights. Now, if you want to know what the vision is, well, why not go to the top? President Obama announced the Precision Medicine Initiative in 2015 and said, or at least is quoted for, until now, most medical treatments have been designed for the average patient. As a result of this one-size-fits-all approach, treatments can be very successful for some patients, but not for others. Precision medicine, on the other hand, is an innovative approach that takes into account individual differences in people's genes, environments, and lifestyles. It gives medical professionals the resources they need to target the specific treatments of the illnesses we encounter, further develops our scientific and medical research, and keeps our families healthier. So obviously a very good thing. Now, it's important to note that when we come to terminology, it's not clear, and it may be a deliberate ambiguity in what President Obama said, whether he was talking about precision medicine as personalized medicine or precision medicine as hyperstratified medicine. Now, personalized medicine would be the vision where we find the therapy that is uniquely good for you. Now, hyperstratified medicine would be the vision where we're able, by the means of precision medicine, to delineate much more precisely which group you belong to. You're no longer the average patient, but you still belong to a group of patients. And it's that group we can say something about. And these two visions are very often run together, but they are distinct. Now, there's no direct implication from the detailed and personally unique knowledge about my genomics to personalized medicine. My genomics or any other omics knowledge might be irrelevant or it may not provide a conclusive answer. Now, in the Obama statement and many other statements, we also see environment and lifestyle mentioned. But in many actual implementations of precision medicine, these seem to fall out. It all becomes about what we can find in your genome or one of your many other omes. Now, the first problem I want to highlight is what you would call the other diseases of pharmaceutical products problem. Now, we have had some very significant successes in precision medicine. We have had successes in oncology and in some narrow areas of pharmacogenetics, where there are large differences in metabolism of a drug, which has significant side effects. Now, the problem is whether from that we can deduce that we will have the same kind of success in relation to common conditions. High blood pressure, ischemic heart disease, osteoporosis, you choose whatever you think is a nice common condition. Or will we have the same success in commonly used drugs for these diseases? Or will we, for some of the drugs, use the information we could have? It's for a long time, for instance, been known that there are very large differences, genetically determined differences in metabolism of codeine, and that for a large segment of the people who take codeine, they will have no analgesic effect at all because of the way they metabolize it. Now, we don't currently do genetic testing for codeine metabolism. In the future, we could deduce it from the full genome sequencing, but it still raises the question, will we use it? Will my general practitioner look into my full genome to see whether what kind of codeine metabolizer I am before prescribing this drug? So there's some interesting questions about whether the current vision is something we will see, at least in the near term, only exploited in some very, very specific disease groups and for some very specific pharmaceuticals. Now, whatever vision of precision medicine you take, in the areas where it's successful, it will create a problem for the randomized controlled trial. Now, in current randomized controlled trials, the control group receives the best proven intervention or the standard treatment. Now, this has both ethical and methodological reasons. The ethical reasons have been discussed very much in relation to the changes to the World Medical Association's Declaration of Helsinki. The current version from 2013, the benefits, risks, burdens, and effectiveness of a new intervention must be tested against those of the best proven intervention, except in the following circumstances: where no proven intervention exists, the use of placebo, no intervention is acceptable; where for compelling and scientifically sound methodological reasons, the use of any intervention less effective than the best proven one, the use of placebo or no intervention is necessary to determine the efficacy or safety of an intervention, and the patients who receive any intervention is less effective than the best proven one, placebo or no intervention, will not be subject to additional risks or serious or irreversible harm as a result of not receiving the best proven intervention. Extreme care must be taken to avoid abuse of this option. So the Helsinki Declaration says that we should, morally speaking, design our RCT so that the control group receives the best proven intervention or standard treatment. Methodologically, we have good reasons to do it as well, because hopefully we want to show that our new treatment is actually better than what is already available. or it is not worse but cheaper. So we have methodological reasons for that comparison as well. Now, the problem that successful precision medicine might lead to is a situation where we can no longer identify what the best proven intervention or standard treatment is in relation to a particular condition. We might be able to identify it in relation to a particular person or a small group of persons, but not in relation to a condition as we do now. And if we are really successful and get a very hyper-stratified treatment scenario for a particular condition, we might not be able to define any homogeneous control group. We might simply have divided patients in so many groups that we don't have a control group which can get the best proven intervention or standard treatment. Now, this creates a problem in relation to research ethics. It creates problems in relation to the methodology, and it also creates some problems in the clinical encounter, which I'll talk about later. Now, one suggestion to this is that we should just stop doing randomized controlled trials, and if I can get this to work, we should do N=1 trials. So in precision oncology, we should simply do all our genomics. We should give the patient the drug that seems to be best, knowing everything we know about the patient, and we should see what happens. Now, of course, what we're really interested in is whether the patient survives or not, and for how long. But hopefully that takes a long time to find out. So in these trials in oncology, we go for the sort of semi-soft measurable endpoint, which is tumor size, which correlates somewhat, but not perfectly, with the desired hard endpoint, which is survival. Now, we can also do N=1 trials in chronic conditions. People have been thinking for some years about what the conditions that are necessary for these are, that the disorder has to be chronic, stable, slowly progressive, or frequently recurring relapsing, that there are significant individual differences in treatment effects, that there's rapid onset of action, and importantly for the outcome measurement assessment, that there are validated, repeatable measures, that is, biomarkers of treatment effects. So again, we are looking at a soft or semi-soft measurable endpoint instead of the desired hard endpoint that we are really interested in and which the patient is presumably really interested in. So N=1 trials create a risk of treating the soft endpoint and not the disease because of the need to identify treatment success relatively quickly on the basis of measurable interim endpoints. Now, this will create problems in multifactorial conditions in heterogeneous patient populations, and these problems might be quite significant. We have many historic examples where we have treated pathological findings, blood test results, ECGs, and many other things, and we have been able to generate perfect ECGs, for instance, in some of these examples. So remove all of the abnormalities in the patient's ECGs, but unfortunately with the side effect that we significantly increase the risk of these patients dying. And there are numerous examples from the history of medicine, that things can go terribly wrong when we look at interim endpoints and not the hard endpoint that we really want to create. Now, the problems for the RCT also creates a problem in clinical epistemology. Now, what is the physician's justification for saying this treatment is best for this patient? Currently, in theory, and as the basis for the whole edifice of evidence-based medicine, this is supposed to be translation of randomized controlled trial evidence, which clearly is on the group level, to this particular patient. And we all know of the many issues that it creates, because in randomized controlled trials, we often have a highly selective group of patients which looks nothing like the group of patients who are actually treated in clinical practice. But our supposition is that clinicians can take account of the fact that this patient not only has the disease or condition for which we have randomized controlled trial evidence, but also 2 or 3 other diseases or conditions which might interact with this, and translate all of this evidence to the particular patient. Now, this creates a number of problems. Well, how do we translate evidence from previous N=1 trials? And how should we proceed with treatment choice if either there's no access to the relevant omics evidence, or the kind of evidence I have is different from the one that was used when the particular drug or treatment was developed? So it creates a range of new issues for the clinician, how the clinician is supposed to translate the evidence base to the patient. And of course, it also creates very significant problems for the evidence hierarchy of evidence-based medicine. And some of you might say, well, not before time. But we'll leave that for another time. I'll now move to the second part of my talk, which is on patients' rights. Now, in relatively well-funded public healthcare system, we assume that patients have a right to the best possible treatment, which obviously generates the general resource allocation issue, and more specifically in this context, generates the issue of who should bear the cost of precision medicine. Now, the optimistic answer is, oh, that's no problem. Cost will fall. Cost will fall because we are able to identify precisely who should have which treatment. We're not going to waste treatment. It's going to increase efficiency hugely, so cost will fall. Now, I think that on current evidence, that is highly unlikely to happen. No healthcare system in a rich democracy has ever been able to get costs to fall, except for a few years, after which time costs have risen again. And in most of these healthcare systems, they rise year by year. So it's highly unlikely that the no problem scenario will obtain. Then we could have a slightly less optimistic answer. Well, there's no problem. Costs might not fall, but they will be stable. What will happen instead is that results will improve. through better outcomes and a reduction in side effects. So we'll get more bang for the buck, more health for our money. Now this is slightly more possible, although perhaps again not likely. It is quite possible and probably true that we will improve health outcomes. Now we can see that over time as well in most of our healthcare systems, that over time we do increase health outcomes over time. Average life expectancy increases and so on. And it might be possible to do that with the same cost base. We might be skeptical on the other side, because if we sort of do an inductive argument from previous experience, we will know that a lot of the interventions in medicine where we were told, well, these are going to drive down costs, or costs are going to be stable, didn't really work out in that way. So we might be skeptical, but let's assume that cost will be stable. We still have a problem, because the benefits, at least for the foreseeable future, are not likely to be evenly distributed between disease groups. Precision medicine is much more likely to help people with cancer, because a lot of the effort is being put into that area, than it is to help people with other diseases. Now, whether you see this as a problem depends on whether you are an egalitarian, whether you think that equality is important, and what kind of egalitarian theory you subscribe to, and also whether the change that follows the introduction of precision medicine is actually Pareto-optimal or only potentially Pareto-optimal. We might end up in a situation where it's true that the patients who do better could compensate those who do worse or not do as well, but it doesn't happen, which would make the change only potentially Pareto-optimal. Now, the second problem in relation to patients' rights and rights to the best possible treatment is in relation to what we could call residual groups. Now, in the ideal situation, our omics investigations plus use of AI plus something not yet invented it will lead to a situation where precision medicine allows us to identify an effective personalized treatment for every patient suffering from a particular disease. Now, the likely reality is that we won't get this kind of personalized precision medicine, or won't get it anytime soon. We'll have hyper-stratified medicine, which results in some patients getting something when they have been identified, which is an effective personalized treatment, but a significant residual group of patients who are allocated to what we could call early 2000 standard treatments, because they don't fall into any of these groups where we identify a particular treatment which is specifically good for them. So we'll see an increasing disparity between beneficiaries of precision medicine and the residual group, and over time potentially decreasing incentive for further research when the residual group becomes small. Now, this is also a problem, and it's a problem that will be discussed in other sessions as well, because the benefits of precision medicines are not likely to be evenly distributed across important equality criteria like gender, ethnicity, race, and other criteria you might think of. So, in the likely scenario for precision medicine, we know that we are going to create a number of inequalities, and we have to make a judgment about whether the benefits that precision medicine will create outweighs the inequalities that it will almost inevitably also create.